Good morning, ladies and gentlemen. I'll be talking on a very important and pertinent subject that may be of interest to the students, the multi-drug resistant organisms that are a problem in all Indian ICUs and the antimicrobial choices that we have. Now, this is adopted from the IDSA guidelines. So this would, the use would require caution because you need to look at the organism that you are harboring in your unit and the antibiograms that you have in your hospital. So we'll start with the difference between the gram-negative and gram-positive. We know our bugs are predominantly gram-negative. As you can see here, the structure is quite different. The peptidoglycan layer that is quite thick and tightly adherent to the plasma membrane in gram-positive bacteria is very thin here. Peptidoglycan is basically a polymer of amino acid and peptides. Here it is very small, and there is an outer membrane present that you can see. It is made of lipopolysaccharides and phospholipids. So it offers resistance, confers resistance to this gram-negative bacteria. As a result, the serious gram-negative infections, we generally combine antibiotics. That is the reason. These stain, gram-negative stain pink or red, these stain violet or purple when we do gram staining. And these are gram-positive are more susceptible to the antibacterials as compared to gram-negative. So these are the differences, and our bugs are predominantly gram-negative. That you have to understand. So what do we need to know before we start using our golden hand to prescribe antibiotics? Well, we need to know about the antibiotics, their mechanism of action, the posology, PK/PD profile, the resistant mechanisms, and we should know about our bugs in the hospital as well as the antibiogram. So let us first recapitulate how the antibiotics, are grouped by different mechanisms. So we have cell wall synthesis, antibiotics which are acting on cell wall synthesis, inhibit the cell wall synthesis. Penicillins, cephalosporins, beta-lactamase inhibitors, carbapenems, estuamine. So large number of antibiotics will work by inhibiting cell wall synthesis. Whereas we have another large group which work by protein synthesis inhibition, where they may be targeting 30S ribosomal subunit like the aminoglycoside or tetracyclines, or the 50S subunit of ribosome like macrolide, clindamycin, chloramphenicol, linezolid, etc. There are drugs like fluoroquinolone and metronidazole which inhibit the synthesis of DNA. Rifampicin, that is an anti-tubercular drug, is an RNA synthesis inhibitor. Isoniazid, another anti-tubercular drug, is mycolic acid synthesis inhibitor. Sulfonamides, trimethoprim, they inhibit folic acid synthesis. And, the large group of drugs is, among all the antibiotics, is the penicillins, which are bactericidal because they will block cross-linkage by competitive inhibition of the transpeptidase enzyme. So we have penicillins like the older ones, penicillin G, V, procaine, benzathine, etc. So they are active against Streptococcus group A, B, C, and some bacteria like Bacillus perfringens. The problems are hypersensitivity reactions and hemolytic anemia. Aminopenicillin, which includes ampicillin and amoxicillin, are indicated for the above, plus Enterococcus faecalis and E. coli with the same problems. Then we have penicillinase resistant penicillins. So we have oxacillin, nefacillin, cloxacillin, etc. They will work against all these organisms, plus PCNase producing Staph aureus also. So here there is also a problem of interstitial nephritis. Then we have a group called anti-pseudomonal penicillins, which includes carbapenem, ticarcillin, piperacillin. We use ticarcillin, clavulanate, piperacillin, tazobactam. So we combine them with BLIs in our clinical practice. So they also act against, in addition to these, against Pseudomonas aeruginosa, and the problems are same. We have vancomycin, which is bactericidal because it also disrupts peptidoglycan cross-linkage for MRSA and Staph aureus, Staph epidermidis. We know the problems. They are asked in the exam: Redman syndrome, nephrotoxicity, autotoxicity. Then we have the beta-lactamase inhibitor groups, where the conventional or the old ones are clavulanic acid, sulbactam, tazobactam. They are all bactericidal because they will block the cross-linking. They are effective against Staph aureus, Staph epidermidis, E. coli, Klebsiella. The newer ones, which includes avibactam, relibactam, vebrobactam, we'll discuss later. So the problem is again hypersensitivity and hemolytic anemia. Then the most effective and most widely used antimicrobial group, carbapenems, which has imipenem, meropenem, doripenem, ertapenem as the representatives. And they have the broadest cover everything except MRSA and mycoplasma. Aztreonam is a narrow spectrum, mainly for anti-pseudomonal antibiotic and used for hospital-acquired infections. Aztreonam has rebounced now because in India we were not using. The resistance was high because it is destroyed both by AMC and OXA48. So after we have ceftazidime, avibactam, we have started using this combination for our acinetobacter baumanii. We'll talk about that. Polymyxins B and E, typical gram-negative infections. Just remember that polymyxin E is to be used when there is cystitis or UTI, because polymyxin B is not concentrated in urine. Otherwise, for all other infections, the drug of choice remains polymyxin B because it is less nephrotoxic. Then aminoglycosides, which are anti-30S ribosomal antibiotics, and they are bactericidal. So they cover the gram-negative aerobic bacteria, Enterobacterales, Pseudomonas, complications being nephrotoxicity and autotoxicity. Tetracyclines are bacteriostatic. So please remember this. They will block the transfer RNA. Tetracycline, doxycycline, minocycline, demiclocycline, they are all bacteriostatic. They cover Rickettsia, Mycoplasma, spirochetes. And in addition to hepatotoxicity, growth retardation in children less than 12 years, where we don't give it, they also cause a class effect tooth discoloration. Macrolides are again bacteriostatic. They reversibly bind to 50S subunit, erythromycin, azithromycin, clarithromycin. They are effective against urinary tract infections, as you can see here: Streptococcus, H. influenzae, Mycoplasma pneumoniae, and chloramphenicol is bacteriostatic. The drug is coming back because of its spectrum and the MDRO that we are facing. H. influenzae, bacterial meningitis, brain abscess. The problems being aplastic anemia and gray baby syndrome. Clindamycin belongs to the group lincosamide. This is bacteriostatic. It inhibits peptidyl transferase by interfering with amino acyl transfer RNA complex. And it covers Bacteroides fragilis, Staph aureus, cons, Staph and Strepto. It has excellent bone penetration. The problems are pseudomembranous colitis. So it remains a monitored antibiotic in any hospital, and of course hypersensitivity reactions. Linezolid is for resistant gram-positive, so it has a good oral bioavailability also, but largely kept confined for VRE. Streptogramins are not available in India. Then the most commonly used, some of the most commonly used drugs like fluoroquinolones, mostly in OP practice, but also in the hospital. First generation is nalidixic acid. Second generation is ciprofloxacin, norfloxacin, levofloxacin, which covers Streptococcus, Mycoplasma, aerobic gram-positive, as well as Pseudomonas. Third generation is gatifloxacin, which is same as above, plus gram-positive. And fourth generation, moxifloxacin, gemifloxacin, they will cover the all above and gram positives as well. Metronidazole is bactericidal. Metabolic byproducts will disrupt the DNA, and it covers all anaerobics. Problems are seizures, cerebellar dysfunction. Then it has reactivity after consumption of ethyl alcohol with disulfiram. Rifampicin, etc., are effective against Staph aureus and Mycobacterium. Isoniazid again, TB and latent TB. Folic acid synthesis inhibitors like trimethoprim sulfonamide, they are bacteriostatic, and they are effective against UTI organism, Proteus and Enterobacter. Pyrimethamine as for malaria, Toxoplasma gondii. Now, another group which is the commonly used antimicrobial therapy in intensive care units, that is the cephalosporins. So we have the first, second, and third generation of cephalosporins, and you can see the spectrum. So as you can see, the third generation, which are the most commonly used, they cover a lot of gram positives, gram negatives, including some Enterobacteraceae, and also cover anaerobes, which are Clostridia species, except the difficile, and Actinomyces israeli. And they also cover the spirochete, Borrelia burdopheri. And fourth generation cephalosporins, they cover a lot of gram positives, as you can see here, as well as a lot of gram negatives, including E. coli, Klebsiella, Proteus, H. influenzae, Enterobacteraceae, and Pseudomonas aeruginosa. They do not cover anaerobic bacteria. Carbapenems have the largest cover, so a lot of gram positives, Listeria, and Haemophilus influenzae, Neisseria, Enterobacteraceae, Pseudomonas. Then among the anaerobes, Bacteroides, Fragilis, and most other anaerobes. This is the spectrum. Another thing that we should know is what are the tests which are available for confirmation for carbapenemases. Now, modified Hodge test, carbapenemase inhibition, amino acid amplification, chromogenic agar media. The last three are more sensitive and specific. They have a high sensitivity and specificity, and they can also differentiate different carbapenemases. And but this is of more relevance to the microbiologists. Now, this is a very important slide. So it depicts all the resistant mechanisms by which the bacteria outsmarts all classes of antibiotics. So you can see a common thing here, loss of porine channels. So the entry points for, the porine channels are the entry gates for nutrients into the bacterial cytoplasm, as well as into the movement of the excretory product outside. So there is loss of porine channels. So you find that happening in Pseudomonas, that happening majorly in acinetobacter. And if at all they gain entry here in the periplasmic space, as you can see, then they are destroyed by the ESBLs, which are, includes carbapenemases also. And then if at all they survive that gain entry, they will be thrown out. Bacteria is using energy, ATP pumps are being used, and it throws out from the efflux pump. So it is, bacteria will have more overexpression of the transmembrane efflux pumps. So that is what is happening. And then you can see that the antibiotic modifying enzymes are there in the bacteria. Then the bacteria can cause target mutation, whereas the fluoroquinolones may not work because the target is mutated now, or it can cause ribosomal mutation or modification so that aminoglycosides, tetracyclines, they cannot work, or it can modify the lipopolysaccharide structures again, so that the polymyxin class is affected adversely. And it can also bypass some of the targets affecting trimethoprim, etc. So, and of course, It can jump across the population by having, plasmid-mediated resistance genes. So all this is how bacteria have evolved over millions of years. And for whatever, remedy we have got, whatever advancement we have got in terms of antibacterials, the bacteria has developed within no time a unique mechanism to counter that. So far, there is an ongoing battle between the bacteria developing these resistant mechanisms and humans trying to develop more and more antibiotics. But there is a fatigue that has set in, and as we know, the pipeline is almost dry now. This is the classical NEGM cartoon showing the resistant mechanisms of acinetobacter baumanii, and here you can see. This is the outer membrane that you can see. This is the periplasmic space, and this is the cytoplasm. So here there is loss of these porine channels or entry points, and there is active overexpression of efflux pumps. There are a lot of ESBLs in the periplasmic space, and then this is plasmid mediated. So we follow, because of the extended ESBLs, we follow the Ambler classification. That is a simple classification which is based on amino acid sequence of the beta-lactamase genes that are present in the bacteria. We have class A, B, C, and D. Broadly speaking, class A includes most common ESBLs like CTXM, TEM, SHV. Class B is metallo-beta-lactamases. These contain a zinc ion in their active site, which helps in the hydrolysis of beta-lactam antibiotics. So the examples are WIM, IMP, and the notorious NDM1. Class C is also called MC beta-lactamases. They're chromosomally encoded, and they're mainly distributed in Enterobacterales and Pseudomonas aeruginosa. Class D beta-lactamases are oxacillinases, primarily distributed in Acinetobacter baumanii. So when we look at this whole thing in slight detail, you can see here, this was a classic paper published in, I think, 2010 or 2012 in New England Journal. And you can see the classification. Now, this is class A, which will include the broad spectrum, expanded spectrum, and the carbapenemases, which include KPCs. And you can also see the inhibition by clavulanic acid. So the next we have is a molecular class class B that we discussed, and then MC, class C. And then we have the class D, which contains the traditional broad spectrum oxa family, as well as the expanded spectrum oxa family, where we have the oxa 48 and other things as well. Now, what are the major MDROs that we have in India? ESBL-E or Enterobacterales, CRE, Carbapenem resistant Enterobacterales, GTRP, that is difficult to treat resistant Pseudomonas aeruginosa, AMP-C producing Enterobacterales, and Carbapenem resistant Acinetobacter baumanii. These are the major bugbears. So these are the major MDROs, as you can see. So we have a lot of problem with crab, AMP-C, and difficult to treat Pseudomonas, as well as CRE. So let's see what is the recommended strategy by IDSA. So the first bug is ESBL producing Enterobacterales, which include E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Proteus mirabilis. And the most common resistant mechanism in the US here is CTXM15. That is the ESBL. TEM and SHV are also there, but they are narrow spectrum. So generally, when there is ceftriaxone, MIC is more than 2 microgram per mil, and the bug is non-susceptible, this is taken as a proxy for ESBL production by the labs. So here, what is recommended is for uncomplicated cystitis, nitrofurantoin and trimethoprim can be used, or a single dose amikacin as an alternative, or amoxiclav for 3 days. Oral fosfomycin, a word of caution because it can be hydrolyzed by fossa gene in K. pneumoniae. Pyelonephritis and complicated UTI, penems, ertapenem, meropenem, imipenem, cilastatin, or ciprofloxacin, levofloxacin, or trimethoprim sulfamethoxazole. Fosfomycin is an alternative only if there is E. coli infection, 3 gram oral daily for 1 week, followed by 3 gram orally every 48 hours for 6 to 12 weeks. Infections which are outside the UTI, they are of concern to us, like the bloodstream and the VAP. Carbapenem remains the first choice. There is no oral step down here. And we also need to understand that for pyelonephritis and complicated UTI, piperacillin tazobactam is not recommended. Cefepime is not recommended, even if it shows susceptibility. Cefamycins are, like cefoxitin and cefotitan, are also not recommended. Next problem is Enterobacterales, which are AMC producers. Now, this AMC is produced by one of the three mechanisms. Either there is inducible chromosomal resistance or stable chromosomal derepression, or via plasmid-mediated AMC genes. Isolate with constitutive AMC are non-susceptible to ceftriaxone as well as ceftazidime. So when it comes to treatment, when there is moderate to high risk of AMC production, ceftriaxone and ceftazidime are not recommended. Cefepime is recommended only if MIC is less than or equal to 2 microgram per mil. Piptazo is not recommended as tazobactam is less effective at inhibiting AMC hydrolysis when compared to newer beta-lactamases. We'll talk about that. Carbapenems are showing when they show sensitivity. They are recommended when they show sensitivity. And the MIC for cefepime is more than 4 microgram per mil, and ESBL coproduction is also present. Clinical outcome data for the newer ceftolazone, tazobactam for treating AMC Enterobacterales infections is limited. Trimethoprim sulfamethoxazole or fluoroquinolones can be considered as either IV or oral, but step-down therapy. Nitrofurantoin, trimethoprim sulfamethoxazole, single dose IV, they can be considered, but only for uncomplicated cystitis. The next important bug is CRE or carbapenem resistant Enterobacterales. Carbapenemases, all of us know, are major mechanisms in the USA, and KPC can be produced there. KPC is a major bugbear in the US ICUs. Other mechanisms are NDM1, which is a metallobeta-lactamase, WIM, Venona integron encoded metallobeta-lactamase, IMP imipenem hydrolyzing MBL, and oxacelinase, OXA48. So OXA is class D and NDM, WIM, and IMP are class B. So it is very important to identify CRE or non-CRE. And we should know, if we look at the data in the US, when they looked at the carbapenemase gene prevalence, 35% of the isolates, the KPC was in 86%, NDM1 was only 9% in the US data, others were even less. So whereas in India, I think our predominant problem is NDM1, we have very few of Klebsiella pneumoniae carbapenemases. So this we need to understand. So how do we treat these infections? Uncomplicated cystitis, well, the choices could be ciprofloxacin, levofloxacin, trimethoprim sulfamethoxazole, nitrofurantoin, or single-dose aminoglycoside. Alternatives could be colistin and no polymyxin B because it does not get into the concentrated into the urine. So for bladder as well as urinary infections, colistin is the polymyxin of choice. Pyelonephritis and complicated UTI, again, cipro, levo, trimethoprim, and sulfamethoxazole. If the carbapenem resistant CRE is to both ertapenem and meropenem, then the choices are ceftazidime avibactam, the new BLBLI, meropenem vebrobactam, imipenem cilastatin relibactam, and cefiderocol. So out of all these, only ceftazidime avibactam is available in India. And if resistance is only to ertapenem, then extended infusion of meropenem can be used, and but data is insufficient to prefer one over the other. Otherwise, there is If there is resistant to meropenem, then it is not recommended. Infections which are outside the urinary tract, well, WAP or bloodstream infections, if only it is resistant to ertapenem, then extended infusion of meropenem can be given. So please understand, here in MDR infections, whenever you are using meropenem, give a big bolus, say 2 gram, and then followed by extended infusion, which can be given for a period of 1 to 2 hours. Otherwise, ceftazidime, avibactam, aztreonam, if it is resistant to both ertapenem and meropenem, so that could be the drug of choice. And carbapenem testing, if it is not available, then also we go for this combination. And or the newer agents like meropenem, vebrobactam, imipenem, cilastatin, relibactam. A little bit about the various combinations. Aztreonam, particularly combination of ceftazidime, avibactam, and aztreonam. We know aztreonam is a monobactam. It is a known anti-pseudomonal agent, but it is hydrolyzed both by AMC as well as OXA48. It is not impacted by NDM1. So combination therapy, when we are combining with ceftazidime, avibactam, one thing we should know is that there is no combination antibiogram available. So the data on percentage of NDM isolates which are susceptible to this combination is not available because there are no standards available. Its comparison with cefiderocol is also not available. Resistance to ceftazidime, avibactam occurs due to mutation of BLA-KPC genes, translating to amino acid changes in permeability and efflux. So it will be more of a problem in the US ICU, where the resistance is estimated to be about 20% to ceftazidime, avibactam. Polymyxin, again, CLSI has made a change. All of you know that now they are reported as intermediate because they eliminated susceptible category, which was based on concern about clinical effectiveness of polymyxins and accuracy of their susceptibility testing. And combination therapy is not routinely recommended for infections due to CRE, that we need to understand. So moving on further, the next bug is Pseudomonas aeruginosa, the difficult to treat Pseudomonas aeruginosa. Mechanism of action of resistance development here are a little different because it's a problematic bug. There is decrease in the porine channels or the entry points, and there is increased production of AMPC. There is upregulation of efflux pump also, and there is mutation of the penicillin binding protein as well. It is not basically because of NDM1. So this is something that we should remember. So if susceptible to piptazo, ceftazidime, cefepime, aztreonam, these drugs are preferred over carbapenems. If Pseudomonas is not susceptible to carbapenems, but to traditional beta-lactams, then high-dose extended infusion should be used. So the recommendations for uncomplicated cystitis are novel beta-lactams, ceftolozane, tazobactam, ceftazidime, avibactam, imipenem, cilastatin, relibactam, or single-dose aminoglycoside. Alternatives could be colistin, like I said before, for bladder and for UTI, only colistin, as polymyxin B is not concentrated in urine. There is no role of oral phosphomycin. Complicated UTI or pyelonephritis, again, novel beta-lactams, all 3 of them, or cefiderocol or amikacin once daily. Infections which are bloodstream or WAP, which are outside the UTI, again, all 3 novel beta-lactams, as you can see here, or cefiderocol as an alternative option. So these are the things. So that means the difficult to treat resistant Pseudomonas aeruginosa is a problem, and we should understand that when we have bloodstream and other infections, the choices are limited. So ceftazidime, avibactam, imipenem, cilastatin, relibactam, or cefiderocol, or ceftolozane, tazobactam. These are the options. Out of this, only ceftazidime, avibactam is available. Moderate to severe disease. resistant to carbapenems but sensitive to beta-lactams. Here, piptazo, if the MIC is less than 16/4, or ceftazidime when MIC is less than 8 microgram per mil, cefepime less than equal to 8 microgram per mil, aztreonam less than equal to 8 microgram per mil. Carbapenem resistance is due to lack of or limited production of OPRD, which facilitates entry of carbapenem into bacteria. Choices are ceftazidime avibactam, imipenem cilastatin relibactam, ceftalozone tazobactam, and the alternatives are novel beta-lactams. Again, ceftalozone tazobactam, ceftazidime avibactam, imipenem cilastatin relibactam. And we need to select the after sensitivity testing to preserve these molecules. So use only when sensitivity testing has been done. The last one is crab. Deadly carbapenem resistant acinetobacter baumanii, very smart bacteria. Resistant mechanisms are carbapenem for carbapenem resistant acinetobacter baumanii. It produces carbapenemases, carbapenem by OXA24, 40, OXA23-like carbapenemases, metallo-beta-lactamases, and additional serine carbapenemases. The resistant to sulbactam is primarily by mutation targeting penicillin binding proteins and beta-lactamase production. Aminoglycoside resistance is by modifying the 16S rRNA in the ribosome. And fluoroquinolone resistance due to mutation in chromosomally encoded quinolone resistant determining regions, as well as upregulation of efflux pumps. Mild crab infections include hemodynamically stable patients with UTI, skin or soft tissue infections, or tracheitis. Here, a single agent ampicillin sulbactam in high dose is preferred. Alternate options for mild crab infections include minocycline, tigecycline, polymyxin B, or if it is only cystitis, colistin or cefiderocol. However, for moderate to severe crab infections, combination therapy with at least 2 agents. So the suggestion in US are high-dose ampicillin sulbactam as a component of this combination therapy. Preferred additional agents may include minocycline, tigecycline, or polymyxin B. Fosfomycin and rifampicin are not suggested as components of combination therapy. IDSA does not recommend use of nebulized antibiotic as adjunct therapy for crab pneumonia. Moving further, combination therapy with at least 2 active agents is suggested for treatment of moderate to severe crab infections wherever possible. Continue with these 2 active agents at least until the clinical improvement is observed. Combination therapy is suggested even if a single agent demonstrates activity. A single active agent can only be considered for treatment of mild crab infections. The data regarding ervacycline, omadacycline is not available. So, cannot say with certainty here. And severe crab infections with a very high mortality, it is recommended that combination of meropenem and colistin or polymyxin B without addition of third agent should not be done, because we need 3 antibiotics. So what they are suggesting is combination of ampicillin, sulbactam, meropenem, and polymyxin B is a consideration, but we should keep in mind the potential for toxicities from 2 high-dose beta-lactam agents. So here what they are suggesting is combining 2 beta-lactam agents in high doses. Fosfomycin or rifampicin as component is not recommended. So triple therapy has been recommended here, which includes polymyxins. A little bit about the novel beta-lactamases. We all have been using clavulanate combinations, tazobactam and sulbactam. Avibactam is a new class because it does not have a beta-lactam ring as these 3 BLIs have. So it's a new class DAPCO, which is diazabicyclooctane. And avibactam differs because, like I said, doesn't have the beta-lactam skeleton. And then the beta-lactamase inhibition is expanded spectrum here. And mechanism of inhibition is reversible. Sorry, mechanism of, it is reversible. Now, when you compare, now this is a very important slide. These are the traditional two BLIs, and Avibactam is the new one. Vebrobactam and Relibactam are not yet introduced in India. So when you look at all the different Ambler class resistant mechanisms, TEM and SHV are handled by all three. CTXM, again, clavulanate cannot handle CTXM, so but Tazobactam and Avibactam does it. KPC is, again, none of the older ones can do it. It is done by Avibactam. Class B, which is metalloenzymes, none of the BLIs, whether old or newer ones, novel ones, they do not have any effect on NDM1 or metallobeta-lactamases. Class C, AMC producing Enterobacterales. Again, all the newer BLIs, Avibactam, Vebrobactam, and Relibactam are effective. Pseudomonas, the AMC producing Pseudomonas, again, all three are effective, but not the traditional Tazobactam and clavulanic acid. Now, here lies the catch. Among the oxacillinases, class D, OXA48 is only inhibited by Avibactam, not by the conventional ones, and neither by Vebrobactam and Relibactam. So this is where Avibactam scores in terms of its spectrum over others. So the same thing, the BLBLI's combinations have been compared with other newer antibiotics. So all these are new: plasmomycin, ervacycline, temocillin, cefiderocol, and these are the BLBLIs. So you can see. Now, if you see, let us pick up one which is available, which we are using. Ceftazidime Avibactam. ESBL and AMC producer, good action. KPC is good action. OXA48 good action. MBL no action. And Carbapenem susceptible acinetobacter baumanii no action. And plus minus for Carbapenem non-susceptible Pseudomonas aeruginosa. Now, if you see, cefiderocol has action against ESBL, AMC, KPC, OXA48, MBL, Carbapenem non-susceptible acinetobacter baumanii, and here also. So we will have to see how the drug fares here. But Tazobactam, Vebrobactam, Relibactam, none of these have action against OXA48. Avibactam has action. Cefiderocol has action. Plasmomycin, eravacycline also have action here. So when we look at the ceftazidime Avibactam, the dose is 2 grams of ceftazidime and 0.5 grams of Avibactam. Generally, frequency is 8 hourly, and it's given as infusion over 2 hours. When you are combining it with aztreonam, then both infusions should continue simultaneously. The duration of treatment for complicated intra-abdominal infection is 5 to 14 days. For complicated UTI, pyelonephritis, 5 to 10 days. For hospital-acquired pneumonia, VAP, it is 7 to 14 days. And this was one study which looked at 102 BSI samples, which were MBL producers, and where they compared the ceftazidime Avibactam plus aztreonam combination with all other antibiotic combinations. And they found that here 51% patients were given this ceftazidime Avibactam aztreonam combination, and there the mortality was much less, as you can see, 19.2%, compared to other combinations where the mortality, which contained colistin, all the combinations contained colistin, but the mortality was quite high. And among the regimens which were not containing colistin, the mortality was a bit low. But remember, this is MBL producing Enterobacterales, not crab. And lastly, a bit about the newer molecule. Cefiderocol is a synthetic conjugate which is composed of cephalosporin moiety and a catechol type siderophore. Now, this will bind to iron, and this will facilitate bacterial cell entry using active iron transporters. Once it enters the periplasmic space, the cephalosporin moiety will dissociate from iron, and this will bind primarily to the penicillin binding protein, and then it will inhibit bacterial cell wall synthesis. That is how it works. Plasmomycin is a new aminoglycoside, recommended for complicated UTI and pyelonephritis. Has similar side effects of nephrotoxicity and ototoxicity. Dose is 15 milligram per kg QD. Eravacycline is a tetracycline, so it inhibits bacterial protein synthesis, indicated in complicated intra-abdominal infections. Dose is 1 milligram per kg IV BD for 4 to 14 days. Side effects like other tetracyclines, important one is permanent tooth discoloration. So here you can see the various drugs which I have discussed. And my final remarks are antibiotic selection in MDRO infection is quite challenging. Information about carbapenem resistant mechanisms is very helpful. So we now have Carba-R, which is available, which tells us about IMP, WIM, OXA48, and NDM, etc. So, and CTM and SHV. So this must be done to fine-tune our antibiotic therapy. And one word of caution that we should not only be looking at the sensitivity or the MIC values, it is the MIC by breakpoint which is important. So we need to know the breakpoints as well. Pseudomonas and crab are difficult to treat organisms. We should avoid using novel BLBLIs like ceftazidime avibactam as empirical therapy to avoid development of resistance. And finally, IDSS suggestions, although they are evidence-based, but they may not be fully applicable to our Indian patients because of the different resistant patterns and the different kind of resistant infections that we have. So I think it is required that we need to monitor our hospital flora, publish the monitor flora in the hospital, and then also look at the antibiogram and direct our therapy specifically, keeping the broad guidelines given by IDSA in mind, but they should be locally adapted as well. Thank you very much for watching this. And this will be followed by a next very exciting lecture where the students will be introduced to the concept of infectious disease. How does an ID perspective add value to these multi-drug resistant organisms or infections caused by these organisms? Thank you very much for watching. Thank you.